Probably between 23 and 25 Celsius.
Oh, that's
Same
lovely.
as us. We are 23.
Yeah.
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 But for us, it gets very warm. Then it goes like up in 40s.
Yeah. The
Then we-
hottest we ever get is about 28, I think.
You're lucky. You're lucky. 40 is
There
no
isn't
fun.
anyone here. Yeah, there isn't anyone here that has either air conditioning or heating. So it would be nice to have heating sometimes, but all right. Well,
Experience.
Yes.
Have to tell us how is there. So
Christina, we will bring you to India when the temperature is close to 50 and you won't be jealous of our savings. I can tell you that.
Yeah, you must visit May to June. You're more than welcome.
And then you will start loving air conditioning also.
Yes. And you will definitely ask for a walkie-talkie like air conditioning. Permanently.
I think everyone's on now. So
Yes, we better behave ourselves.
yeah.
I think they all know us now for 27 months, 26
Yes,
months, but they know what
26.
we are. So we can be just ourselves. 26
Yes.
months, yeah. I mean, Manfred had made such an amazing,
Yeah. Did you want to say something to begin,
yeah,
Vishali, or
same. Okay,
we-
okay. All the panelists, I'm sorry about this. The questions, answers will be typed in Q&A box. We do not have time to take up all the questions towards the end. So please keep on typing the answers. Mostly related to you, but even if they are not related to your topic, you all are experts, you can just answer. So that towards the end, we generally take up more of a controversial questions rather than the routine answers. So please, at the end of your talk, go to Q&A and, answer any questions. You can interact, you can answer. So it would be.
okay? Do you want to take it, Rima?
I'll just introduce and then
Okay.
you will alternate. I'm just going to.
Yes. Okay.
Yes, a very
let's
good
start.
evening. A very good evening once again, all of you. So before you guys joined, I was just telling everybody that we are now like family. It's almost 26 months. We have been meeting each other every first Saturday of every month. So it's like we know each other. So as usual, the questions to be typed in the Q&A box. Whatever questions related to sympathetic ophthalmia will be answered by the experts. And at the end, you will receive an email. The email you have to reply back, and then you get CME credit hours. And most of you would know, but if some of you are new, you can write to us anytime to know about the procedure, but you will receive an email within 2 days of the webinar getting over. And as usual, we look forward to your inputs that helps us in improving on the webinars and customizing it to your requirements. With this, I will pass it on to our moderators, always Rima and John Kempen, who are helping IUSG a lot with these educational activities. Thank you for being there, and over to Reem.
Thank you, ma'am, and very good evening to all of you. So with this, we now begin a series of talks on this session on sympathetic ophthalmia. So we have Professor Dara Kilmartin, who will be giving the first talk on epidemiology of sympathetic ophthalmia, past, present, and future, Professor Kilmartin is an associate clinical professor of ophthalmology and a consultant ophthalmologist and vitreoretinal surgeon in Royal Victoria Eye and Ear Hospital, Dublin. Professor Dara Kilmartin.
Thank you. Can you see my screen now?
No.
Not yet.
Are you sharing?
Yes, I am.
So our backend team, would you like to help Dara with?
Sir, please open your presentation. Yes, sir. Please slide some more, sir. Full screen mode.
Okay.
Perfect. Yeah.
Platform start. Yes, sir. Okay.
All right. Thank you. Sorry about that glitch. Thank you very much, Vishali, for hosting and coordinating this seminar on sympathetic ophthalmia. I've been asked to speak to you about the epidemiology of sympathetic ophthalmia, past, present, and future. My background is that I conducted, along with John Forrester and Andrew Dick, the first prospective study on a national basis of new cases of sympathetic ophthalmia occurring through the British Ophthalmic Surveillance Unit between 1998 and 2000. And this data was widely published. Now, this data is quite old now, but it still has relevance to current trends. So as we know, sympathetic ophthalmia is an uncommon bilateral granulomatous panuveitis following penetrating trauma to one eye. It generally is accepted that the rate of occurrence following accidental trauma is about 1 in 1,000, and about much less following surgery. But the population instance, as determined from the Bossu study, was determined to be 0.3 per 100,000. So it's quite a rare condition. And why are we spending our pleasant Saturday afternoon talking about it if it's so rare? Well, it's important despite its rarity because it acts as a classic role model for autoimmune disease. And its importance is increasing because of the increasing causative role of ocular surgery, which from this prospective study, we now believe to be more important than accidental trauma. It was shown in this study that the risk of developing sympathetic was 1 in 800. It is probably the most feared surgical complication of vitreoretinal surgery. And unfortunately, the diagnosis following surgery is often delayed, possibly due to the underappreciation of sympathetic ophthalmia amongst vitreoretinal surgeons and the lack of familiarity with uveitis management amongst the vitreoretinal surgical workforce. It has major medical legal implications, not least of which the old idea of the role of enucleation in severe ocular trauma, and the risk of operating in an eye that has a history of previous trauma, and the landmark case of Rogers versus Whitaker. So it's a very old disease, and we know that it is very rare. What's new? Well, what's new is that we know that there's a disease susceptibility determined by a particular HLA type, and that the disease severity in response to immunotherapy is very much determined by cytokine gene polymorphisms. We have plenty of new agents and new biologic agents that can be used to treat this, which have been shown to be very effective. And there is the potential for tolerogenic peptides, which we've been talking about now for over 25 years. It's more than 2000 years old. It was first described by Hippocrates in the 1st century BC, but was actually well known before that, where he reported that injury in one eye could lead to disease in the other. And 1,000 years AD, the right eye, when diseased, does often give suffering to the left. So it was appreciated through the ages. Louis Braille in France actually suffered from sympathetic ophthalmia when he suffered a penetrating eye injury from a leather awl. The first complete description was by Scottish pathologist Mackenzie in 1840, and the first application of enucleation of the injured eye, which is a very, very old intervention, was by Pritchard in 1854. The first classic description by Fuchs over 100 years ago. And we see that about 70 years ago, Woods described the beneficial use of steroid immunosuppression. So this was quite early on, because really steroids had only were used in any real clinical format from about 1949 onwards. Don Gass described the causative role of multiple vitrectomy, so it's not a new idea. And Chi Chao Chan in 95 showed that early adequate immunosuppression produced a good visual outcome. And Shigeaki Ono in Japan reported an immunogenetic link with sympathetic in Japanese patients. So 22 or 23 years back, the Bossu Sympathetic Ophthalmia study published its first report showing that vitrectomy was now the main cause of sympathetic and confirmed an immunogenetic link. And further reports from that cohort showed cytokine gene polymorphisms can be a good marker of severity. We often think that clinically that Dalen-Fuchs nodules, which are microscopic granulomata, are pathognomonic of sympathetic ophthalmia, but it isn't necessary for these to be present to make the diagnosis. In a typical post-operative presentation, here you can see in the slide on the right, you see fresh granulomata and fresh choroiditis with areas of also inactive choroiditis. And this is in a patient that had bilateral repeat cryobuckling, so an external scleral buckle retinal detachment repair. And this happened 12 years after the first scleral buckle. So it can happen both early and quite late. We know that it tends to focus on the choroid with choroidal thickening and diffuse granulomatous infiltration. We can see lymphocytes, histiocytes, and altered RPE cells within the choroid with relative sparing of the choriocapillaris and retina. The Sun Working Group published diagnostic criteria which required a history of unilateral ocular trauma or surgery with ocular inflammation that is either bilateral, or if there's no view in the inciting eye, then detectable inflammation in the sympathizing eye. There has to be more than isolated anterior uveitis, either anterior and vitreous inflammation, or panuveitis with choroidal involvement, excluding positive syphilis serology or other causes of uveitis such as sarcoidosis. We know that it's a classic autoimmune condition requiring an antigen being presented along with an antigen presenting cell to a resting T cell, requiring accessory and co-stimulatory molecules with activation of T effector cells and release of subsequent inflammatory cytokines. There are many putative autoantigens, either in the retina, S antigen, which is probably the most well studied. I'm sure we'll be hearing about the pathogenesis from Pier Giorgio shortly. But there are other autoantigens, both within the melanin-associated proteins and RPE-associated proteins, producing a CD4 T cell mediated disease. We know that this has a well-defined autoimmune etiology. evidenced by the clinical effectiveness of systemic immunosuppression, by an increased delay type hypersensitivity response to uveitis extract, by experimental animal models being produced from melanin induction, which are very similar to sympathetic, sparing the retina and having spontaneous recurrence. We can see that in patients with sympathetic and in published work from our cohorts that there's both peripheral and vitreous T cell activation and reactivity to RPE and retinal antigens, with immunohistochemistry showing a predominance of CD4 positive T cell choroidal infiltration and TNF alpha staining. There's a precise class 2 association with the DR4 subtype, and both chemokines and matrix metalloproteinase 9 have been shown to play a key role in the migration of leukocytes into the eye in sympathetic. So the requirement is a breach of the blood ocular barrier with usually a penetrating eye injury, but we know that blunt trauma can do this. And this is often enhanced with adjuvant-like molecules entering the eye and enhancing immunogenicity, endotoxins or lipopolysaccharide molecules, as would be seen in bacterial infection, leading to activation and release of antigens either from the uvea or retina, and so local lymphatic drainage and local lymph node tracking within a very, very short period of time. In animal models, as quickly as 45 minutes after an injury. So this usually takes a week to decades later, and the clinical manifestation of sympathetic ophthalmia. It's a very old disease, and we know that from war injuries, it was described with quite wide prevalence in the American Civil War between 1861 and 1865, with a 3.4% incidence of patients developing sympathetic after an eye injury. This is very, very high and hasn't been replicated with future reports, so definitely is an overestimation. The Franco-German War around 1870 showing a much higher rate, but again, probably an overestimation. You can see a dramatic decrease following folks' very precise histopathological studies from 1905. So proper elucidation and characterization of the disease led to a dramatic reduction in its reporting, with only one case out of 800 eye injuries from World War I. And in World War II, again, 1 out of 300. And in the Korean War, not one case was reported, nor was there in the Vietnam War, and indeed none in some reports from the Iraq War, and more recent from American military personnel data. There's very, very few reports, only one report from recent trauma studies. It can occur after any type of intraocular surgery, and indeed we can see that it can happen after other surgeries that don't penetrate the eye. You can see that there's practically no ocular procedure that doesn't produce sympathetic. You can see that even a YAG laser can produce sympathetic when you have cyclotherapy. We can see it after laser trabeculoplasty and cyclodiode laser. So we often think of these conditions as being relatively innocuous, but they can actually produce sympathetic. And indeed, laser retinal photocoagulation has been shown to produce sympathetic, but the classic one now is vitrectomy. So what are the current risks? So we showed from the BOSU data that surgery, in fact, outnumbered trauma in quite carefully collected data. And this has been shown following my own work in Dublin. And these are just some of my very early cases from about 15 years back. And we have about a dozen cases now of sympathetic ophthalmia, freshly diagnosed, attending my clinics, all doing quite well on immunosuppression. So the estimated sympathetic ophthalmia risk from the BOSU study, the only prospective study to date, would be 1 in 800. But we know that, and that's from 1 in 800 vitrectomies. From a scleral buckle, about 1 in 1400. So aggregating all of these out, because that 1 in 800 included repeat vitrectomies, probably after one vitrectomy, the risk was determined to be 1 in 1,300. So why is vitrectomy immunogenic? Well, it's immunogenic because of the breakdown of the blood-retinal barrier with access to sequestered uveitis-retinal antigens in a previous site of relative immune privilege. And we can see that with greater uveitis-retinal trauma, with greater amounts, for example, of cryotherapy, retinal manipulation, and particularly retinectomy, that there's a higher risk of developing sympathetic ophthalmia. And there was a concern that with the progression to microincision vitrectomy with initially 25 gauge and then going back to 23 and now 27 gauge vitrectomy, there was a concern of possible subclinical uveal incarceration, wound leak and hypotomy at sclerotomy sites. And there was a concern that this might be an increased immunogenicity risk and increased potential for sympathetic. So there have been many papers in sympathetic after vitrectomy since the Bossier report in 2000. One case from 2007 in von Grafy's from 304 eyes with retinectomy for complex retinal detachment and established PVR. So the initial early concerns about microincision vitrectomy probably haven't been found. So we can see that from early data from Binder that there was a concern about greater retinal manipulation with 25 gauge vitrectomy. And indeed from Tyaghi's work from an Indian report, that there was a greater proportion of patients in their overall cohort who developed sympathetic that had a microincision vitrectomy. And this may be due to wound leak and hypotony, but it also may be because most of our vitrectomies now are microincision vitrectomies, and there are very, very few larger gauge, 20 gauge vitrectomies being performed. And indeed, from a more recent paper just published last year from Ankina et al. In a retrospective case series of 61 patients at a single unit in Moorfields over the past 15 years or so. Most of these from this case, but again, it's retrospective, were due to trauma, with the commonest inciting a surgical event being vitrectomy. And the estimated risk after one VR procedure was 1 in 12,000, so much less than the Bossier study rate. But remember, this is not a prospective study, and so the data here would not be as reliable. But with increasing numbers of vitrectomy, and this is the quite important aspect of this, the risk increases and increases a lot, such that if a patient is having 7 VR procedures, the risk could go up to as high as 1 in 15. And what about trauma and sympathetic? Well, a meta-analysis of 24 sympathetic ophthalmia studies from Medline, MBase and Cochrane databases showed that there was a 0.2 instance rate, so still quite rare, of sympathetic after an open globe injury. Remember, this is retrospective, so that sympathetic remains still relatively rare. And again, from last year from India and from Parchant et al., more than 75% of sympathetic ophthalmia cases in India occur after penetrating trauma. So this is different from more developed studies and possibly relates to delayed primary care and wound access to good wound repair. And again, retrospective work. So sympathetic ophthalmia remains rare. It's increasing in prevalence due to increasing vitrectomy numbers. Repeat vitreoretinal surgery is now the greatest risk for sympathetic in developed countries, whereas trauma and open globe injury remains the greatest in underdeveloped countries, particularly with the role of adjuvants. Any breakdown of the blood ocular retinal barrier can cause sympathetic, so blunt trauma and laser can do that. And so this is important for consent, which I'll be referring to later. Future risks depend on the potential to break down the blood retinal barrier and breach ocular immune privilege and cause inflammation. So the future of sympathetic and the future of consenting patients will be depending on what type of tissue we're manipulating, how often we're doing that. Remember that we are now injecting patients with intravitreal agents on multiple occasions. And we are seeing, certainly, and I'm seeing this in my uveitis clinic, some patients develop retinal vasculitis due to the use of repetitive anti-VEGF agents, and not just due to brolucizumab, but to all agents. So possibly with the greater use of cyclodestructive procedures, greater retinectomy. And remember that adenoviral vectors are foreign adjuvants, and we're going to be using these more and more with subretinal gene therapy. And could this have a greater propensity to produce sympathetic ophthalmia? Something to think about. So thank you.
Good, thank you very much. And that was a very enlightening talk. And not many of us have too much experience with this. So it's good to hear from someone who's really examined it carefully. Thank you. Next, we have a pre-recorded talk by Dr. Pier Giorgio Neri. He's a staff physician at Cleveland Clinic, Abu Dhabi, which is equivalent to a faculty position, and director of the Uveitis service. And previously was faculty at Polytechnic University of Marciancona. And so let's go ahead with his lecture. If you could play it, please.
Good evening, everyone. It is my great pleasure to lead you into the pathogenesis of sympathetic ophthalmia. This is my financial disclosure. I have nothing to disclose in this presentation. Sympathetic ophthalmia is seen like a nightmare for any ophthalmologist in the world. It's true that it's a rare disease, but potentially it's severe. It's a granulomatous uveitis that can occur after ocular trauma or surgery. We know that we have an exciting eye, which is represented by the injured eye, and we have also the sympathizing eye, which is the fellow eye. The interval between injury and the onset of inflammation ranges from 5 days to 66 years. 70 to 80% occur within 3 months, and 90% within 1 year of injury. The peak of incidence occurs in 4-8 weeks of following injury, and we see that there's a broad range of possible time frames in between the injury and the occurrence of sympathetic ophthalmia. It has a very long history. The first one who described was Hippocrates. And Hippocrates had a lot of other colleagues that many hundreds of years later described in a better way what the possible pathophysiological mechanism might have occurred. In 1840, William Mackenzie noted an association between man and the ironworks sustaining penetrating eye injuries and the development of iritis, photophobia with progression of atrophic bulb eye and poor prognosis. Dellin in 1904 described nodules on the inner surface of the choroid, whereas Ernest Fuchs provided an accurate histopathological description of the disease. In 1910, finally, Eschling was the first to postulate the role of autoimmunity in the pathogenesis of sympathetic ophthalmia. It is important to stress the fact that even for surgery that never had a complication, this can be the case when sympathetic ophthalmia may occur. It is true that it's pretty rare. It accounts 0.06% of cases. In other cases, it was 0.01 when vitrectomy was only operative procedure and penetrating wound. But it is important also to remark what my colleague Dara Kilmartin published in 2000 with a prospective surveillance of sympathetic ophthalmia in UK and Ireland that showed the risk of 1 out of 799 vitrectomies. But looking at the old data, we may see that even a simple cataract accounted 2% as per the report published in 1883 by Stefan. And we see that the incidence reduced along the time, and probably the progress in surgical techniques might have contributed to reduce the incidence. Let's go through the structural damages provided by sympathetic ophthalmia. Let's talk about histopathology. The original description by Ernest Fuchs described non-necrotic granulomas, lymphocytic infiltration, giant cells formation, and pigmented phagocytes. This has been enriched by further description considering the clinical findings in sympathetic ophthalmia, where we saw that there was also the occurrence of Uveitis, cells and haze, papillitis, choroidal infiltration and thickening, serous retinal detachment, and multiple yellowish white spots in the periphery beneath the RPE called the Dahlem-Fuchs nodules. It is important to see what has been described by Chi Chao Chan and co-authors, where the tissue was studied and the histopathology confirmed a retinal vasculitis. So lymphocytes characterize the vasculitis alongside the vessel wall. At this point, let's have a look to a histopathology model. The normal choroid has a structure that looks like that. When there's an active disease, we can see that we have the bloodstream that is affected. There's a squeezing of the stromal choroidal vessels. The granulomata occurs into the stromal choroidal tissue, creating also bulging on the structure of the retinal pigment epithelium. And then at this stage, we start having the other structures that are affected by this. In the inactive disease, then there is the shrinking of the granulomata, and we see that also there is a rarefaction of the stromal choroidal tissues as well. So when we look at the model and we see what happens, we see that the granulomatas are creating the conditions to have water that is pumped into the subretinal space, and that's the reason why we have the retinal detachment. It is important to see that we have also immunogenetic reasons for the occurrence of this disease. We can see that the immune phenotype has been described in the past. A genetic predisposition, it's very similar to the VKH model. There's an increased frequency of HLA-A11 antigen in patients with sympathetic ophthalmia. And there's also the association with other HLA, as per what has been described by Shindo and my colleague Dara Kilmartin. Looking at the pathogenesis, we see that it's not really clear. Autoimmune inflammation with a predominant T cells response is pretty obvious. However, we need to look into this in a more systematic way. Let's have a look on what Rao and co-authors wrote in the 80s. So the perforation of the globe is the conditio sine qua non that we have to have the inciting eye. Then we have also the sympathetic eye that is affected, and this seems to be given by the fact that the uveretinal antigens have access to the conjunctival lymphatics in conjunction with adjuvants such as bacterial cell walls entering the eye. Then the regional lymph nodes include inducing an immunological reaction towards previously tolerated antigen can occur. Let's say that this is the theory, or better, the hypothesis, that we have an antigen exposure. So following a penetrating eye injury, we have the ocular antigens are normally sequestrated within the eye behind the blood-retinal barrier, become exposed to systemic immune detection. The eye does not have a lymphatic system, which restricts ocular antigens from eliciting a local immune response. Instead, peripheral antigens presenting cells, such as macrophages and dendritic cells, phagocytose injury-exposed ocular antigen. The protein components are processed into antigenic peptides for HLA class second presentation to CD4 plus helper T cells in peripheral lymph nodes or the spleen. The penetrating eye injury disrupts the blood-retinal barrier and allows leakage of ocular antigens into the systemic environment. This is tied to another type of concept that here, in a romantic way, that's what happens as per the beautiful title of the Proctor lecture that Wayne Strailing had a long time ago about ocular immune privilege and the Faustian dilemma. What is, in detail, the ocular immune privilege? Immune privilege was first explored in the late 1800s by Van Dorimel and was then extended by Medawar. Medawar described for the first time the anterior chamber associated immune deviation. ACADE was to determine the downregulation of immune process responsible for graft rejection. Looking more in detail what ACADE is. ACADE is a process that occurs in the eye and helps to regulate the immune response to foreign antigens. When foreign antigens enter the eye, they are taken up by specialized cells called antigen-presenting cells and transported to the anterior chamber of the eye, which is the space between the cornea and the iris. Within the chamber, the foreign antigen triggers a series of immunological events that ultimately suppress the immune response to those antigens. The process of immune suppression is known as ACADE. It involves the production of anti-inflammatory cytokines such as transforming growth factor beta and interleukin-10, which suppresses the activity of immune cells and prevent them from attacking foreign antigens. In other words, we have just a sort of situation where we have a very fragile balance between the forces for the activation of the immune system and the one suppressing it. But sympathetic ophthalmia has also other two components. One is the innate immune system that plays a role in its pathogenesis. But let's have a look to something that is a little bit more fascinating, and is the damage-associated molecular patterns that are released during the ocular injury or the surgery and activate the innate immune system. Let's have a look more in details. So the DAMs are substantially four, the ones involved into this pathogenetic mechanism. The high mobility group box 1 protein, the ATP, DNA and RNA, and the heat shock proteins. Giving a little bit more details about it, we can tell that the HMGB1 is a DNA binding protein that is released from damaged or necrotic cells. ATP is a molecule released from dying cells and can activate the NLP3 inflammasome response. Extracellular DNA and RNA toll-like receptors and other pattern recognition receptors, also known as PRRs, on immune cells. Heat shock proteins are a family of proteins that are produced in response to stress and play a role in protein folding and stabilization. In other words, let's say that DAMPs can contribute to the pathogenesis of many diseases by promoting inflammation, tissue damage, and autoimmunity. And so it does in the case of sympathetic ophthalmia. However, we have to say that we don't know everything and we need to explore other scenarios. But it's very interesting to see that on the basis of interesting publications, the extraocular findings might be possible. Very rare, such as alopecia, poliosis, vitiligo, dysacosia, and cells in the CSF. And there are several complications that we need to consider, and they have to be prevented by being aggressive in the treatment. So when you have a sympathetic ophthalmia, you have to be aggressive. Since in some cases you may have a scenario like this, where you have a very massive involvement of destroyed stromal choroidal tissue, but then once you treat with a very aggressive immune suppression, you can risk the sight of the patient, and certainly the outcome would be better. So the take-home pairs are substantially three. Sympathetic ophthalmia has a precise genotype and phenotype, but we need to more about that. Pathophysiology still has to be investigated, and remember that
So thank you, Dr. Pier Giorgio Neri. And with this, we now move on to the third topic of our seminar webinar today on clinical manifestations of sympathetic ophthalmia, including imaging. And for this, we have Dr. Mamta Agarwal, who's a consultant ophthalmologist in uvea and anterior segment in Shankara Nethralaya, Chennai, India. Over to you, Mamta.
I'll just share my slides. Thank you so much, Rima, for this kind introduction. At the outset, I would like to thank IUSG for giving me this opportunity to speak about the clinical manifestations and imaging in sympathetic ophthalmia. So as the previous speakers has already mentioned, the sympathetic ophthalmia, the latest classification by the Sun Group, we all know that there has to be a history of unilateral ocular trauma or surgery. And there is inflammation either in both eyes or in the sympathizing eye, especially we do not see the inciting eye due to its enucleated status or thiatrical eye or opaque cornea. And there has to be evidence of more than isolated anterior uveitis, including anterior chamber and vitreous inflammation or panuveitis. And it's very important that we exclude infectious uveitis like syphilis and non-infectious like sarcoidosis. So a disease that places the other eye in great danger following injury. It's a bilateral granulomatous panuveitis following penetrating and perforating ocular trauma. What we know is the patients may present with pain in the eye, photophobia, decreased vision, epiphora, or just loss of accommodation due to near vision difficulties. So the clinical manifestations, as we all know, it is usually a granulomatous reaction. So we may see conjunctival congestion with mutton fat keratic precipitates. As we see here, the nodules on the iris, which can be as much as this picture, or they can be very subtle as we see in the bottom picture. These are copies or Busaka nodules. It may also present with just anterior chamber cells and flare with posterior synechiae and vitreous cells. But mostly we know that it may present first in the posterior segment. So what do we see in the acute stage? We see disc hyperemia with exudative retinal detachment, as we see in this clinical picture, the subretinal fluid, retinal folds, and choroidal folds. But sometimes we may have moderate to severe vitritis, and we just perceive that there is disc which looks hyperemic, and we're not able to see the details of the retina. And sometimes we may just have a disc edema with hyperemia. And this is a classical picture, what we know, focal choroidal infiltrates or sub-RPE yellowish nodular lesions, which we all know Dellen-Fuchs nodules. Sharing another interesting case, it's an 8-year-old child who had a history of penetrating stick injury in the right eye, and he underwent vitreoretinal surgery with corneal tear repair. At 1 month follow-up, he complains of decreased vision in the normal eye, the left eye, where we saw visual acuity was 660. And this is what we see on fundus, pockets of fluid disc hyperemia. And he had anterior chamber cells, flare, and vitreous cells in both eyes. So what we see on OCT, again, there is a neurosensory detachment with fibrinous fluid here. And there is choroidal thickness, exudative detachment. Another patient, a 48-year-old man, who complains of decreased vision in the right eye for the last 2 weeks. Unfortunately, the history was very interesting. This was multiple surgeries in the left eye. He started with a rheumatogenic RD, where it was vitreoretinal surgeries done, followed by cataract surgery, and then lens explantation. And he also underwent enucleation because his treating ophthalmologist thought it was sympathetic ophthalmia. When we saw visual acuity in the right eye was 618 with anterior uveitis, mutton fat KPs, and vitreous cells. And fundus, again, there's a pocket of fluid here with fine retinal folds, and FA and ICG, again, quite significantly showing sympathetic ophthalmia. And this was his ultrasound, vitreous opacities, increased choroidal thickness, exudative retinal detachment. And this is, again, we can see these RPE undulations and choroidal thickness, loss of choroidal vasculature, and subretinal fluid with precipitates. And this is again an acute case where we see that history of penetrating injury 2 months back in the left eye, and this is post-vitrectomy, wound repair, and lensectomy. And now he complains that 2 weeks he's not able to see clearly in the right eye. We see subretinal fluid and these retinal folds. But it may not be always so dramatic as we saw in the previous slides. The posterior segment in chronic stage, how does it look like? It's extensive chororetinal damage, and we may see sunset glow fundus with these nummular pigmented peripheral lesions. Or it can be media haze with the sunset glow fundus, and we see this peripapillary, juxtapapillary CNVM, or it's a CNVM in the posterior pole. And sometimes if the patient is not treated adequately, we may see the patient with this kind of a stage, a sunset glow fundus with subretinal fibrosis. And here's one chronic recurrent stage patient. He's an 18-year-old patient in the right eye thicicle, post-perforated ulcer. What we see in the left eye now, granulomatous uveitis and a sunset glow fundus and a peripapillary CNVM, which we when investigated, he was diagnosed. So now he was a sympathetic ophthalmia patient for 2 years, but suddenly he decided to stop treatment. And this is a 58-year-old patient. Again, he was known to have an injury 15 years back in the left eye. And what we see at this presentation, it's a red eye with diffuse KPs, medium-sized, and a sunset glow fundus, again, a peripapillary atrophy, telling probably that he was not adequately treated. And FA does not show dramatic changes. When we look at the OCT, look at the thickness of the choroid. It was just 42 microns, and foveal thickness was 179 microns. We are not seeing any acute changes here. It's a chronic SO. So despite these clinical manifestations, over a course of disease, we may see they develop cataract, not just because of the inflammation, but also because of the oral and topical corticosteroids. They may also end up in having angle closure or open angle glaucoma, as we see in gonioscopy, these synechiae. And sometimes when the patients are not treated adequately, we had a patient who developed disc neovascularization. And when not treated, they may end up having phthisis bulbi. So besides ocular manifestations, how about the systemic manifestations? As mentioned previously, these are the symptoms what we see: meningitis, tinnitus, vitiligo, poliosis, alopecia, and others. But this is an interesting study published recently where the authors, they said, in comparison to VKH, sympathetic ophthalmia has lower extraocular manifestations, and hearing loss is really a rare phenomenon. But does it always have to be so dramatic that sympathetic ophthalmia is so clear with its symptoms and signs? I think this is an interesting case report I came across. It's a 23-year-old patient with a history of penetrating ocular trauma, and he also underwent enucleation. But at 1 month, when he came for a checkup, though visual acuity was 6.6 and 6, no signs of inflammation, but the OCT shows changes in the RPE and a subtle subretinal fluid. And they did an FA where it's a pinpoint leak with disc leakage. And the patient was treated with steroids and mycophenolate mofetil, and this is complete resolution. Another interesting case where, again, it's an early presentation, which is seen on OCT. And this is an interesting patient where the authors, they have done OCT at 23 hours. So looking at carefully, they see that RPE was showing some bumps and EZ zone was probably disrupted. And this is at 12 weeks when the patient actually presented with acute sympathetic ophthalmia, as we see on the bottom left. There is vitritis, there is disc hyperemia, and multiple yellowish nodules. So at this point, what the authors see that this lesion was more pronounced, and at 14 weeks, even more. So this was an early presentation on OCT sympathetic ophthalmia. So they claim that probably we really have to look for these changes at least for a year in any patient who has blunt trauma, even if he doesn't complain of any symptom in the normal eye. So talking about imaging now, we have different tools with us like fluorescent angiography, ICG, OCT, Octa, ultrasound, and autofluorescence. Let's have a look at one by one. So fluorescent angiography, we see that acute phase has two patterns: an early pinpoint multifocal hyperfluorescent leak at the level of RPE, which forms late multilobular pooling of the dye in the subretinal space. And there can be early hypo and late hyper due to staining of the lesions. What about the chronic phase? We can just see extensive window defects because of the chorioretinal adhesions and extensive damage. So this is again showing an early pinpoint leak at the level of RPE and pooling of the dye in the subretinal space, what we know as starry night appearance. Another patient, we see a very subtle pinpoint leak here, which again forms a pool of subretinal fluid in the late phase with a disc leakage. And here we see the second pattern where it's a diffuse hypo with late hyperfluorescence, and we're not seeing those pinpoint leaks. How about indocyanine green angiography? It's a disease of choroid. So this angiography obviously tells us much more than what we see on FA. We see the hyposenescent spots as we see on the picture on the right, multiple hypospots. And that is because there is cellular infiltration of the choroid, Dehlenfels nodules, and overlying edema. So if we compare both FA on the left and ICG on the right, in FA we have early hypo becoming late hyper with a disc leak. But on the right, we see all the hypospots which persist in the late phase. And this is ultrasound just to re-emphasize what we see here is choroidal thickness, exudative detachment with shifting fluid. We may also see choroidal detachment as we see on the pictures on the right. And sometimes disc edema can also be perceived, especially when we don't see the fundus examination. But the most important, I think, my favorite is OCT in these patients. Why? It's a non-invasive tool. And it has very, very good diagnostic science, both in acute stage and the chronic stage. We see these subretinal fluid spaces with or without bacillary detachment. We see membranous structures, we see RPE undulations or loss of choroidal vascular details. We also see increased choroidal thickness and the choroidal undulations. And recently there's a study where the authors, they say that there is increased choroidal vascularity index. So this is a detailed picture, what I want to describe here, the different features seen in one frame. So what we can see from anterior to posterior, there are vitreous cells here, and we can see a big neurosensory detachment. There are RPE undulations, choroid has lost its vasculature, intense thickening of the choroid. And what is interesting here now we know is the bacillary detachment. And what is that? It's a disruption or a break between the outer photoreceptors and the inner segment. And interestingly, we see the membranous structure as we see here, which divides this space into supramembrane, submembrane. And the submembrane, the fluid is optically low intensity, but here it's an optically high intensity fluid because it has the debris and the fibrous material from the disrupted photoreceptors. Here's another patient, again with the same RPE undulations, membranous structures, and loss of vascular details. And the same patient, 2 months post-treatment, everything comes back normal. And again, the same, another patient, we see these choroidal folds and subretinal fluid. And this is post-treatment, everything falls back to normal. And it's again to re-emphasize the choroidal folds, the RPE folds. And this is the subretinal space divided by these membranous structures. We do not see a good detail of the choroidal vasculature, and there's a big neurosensory detachment. And this is a very interesting review article published in OII, and where I picked up this picture, which shows when the OCT is seen through Dehlenfels nodules. So what we see, there is RPE disruption with a nodular hyperreflective lesion. And as we treat the patient, we see the nodular lesion, it dissolves, and this is at completion of treatment, though RPE is still disrupted. So what about the chronic stage? Chronic stage, the choroidal thickness is a good biomarker, which helps us to know how long should we treat, how's the patient doing. And we also come to know about the macular edema, choroidal neovascular membrane, and macular hole, which are the known complications of any chronic uveitis. So this is what we can see. This is a patient with sunset glow fundus. We cannot really see what's happening in the posterior pole because of the intense sunset glow fundus. And this is what we see. This is a cystic space, and we see that choroid is really thin and sunset glow fundus as mentioned. And this is another patient, a patient on long-term treatment. What we see, it's a small pupil, it's a sunset glow fundus. What we pick up is macular edema. And this is another patient, it's a little hypotenuse eye, but again, we really don't see what is happening in the macula, and there are cystic spaces, and again, RPE folds. This is one of the case we published in OII in VKH. We know that both the diseases have similarities. So again, the same thing with the sunset glow fundus. What we are seeing is a peripapillary white lesion, and OCT picks up increased retinal thickness with a hyperreflective lesion and cystic spaces, and the same post-treatment. So OCT is a very good tool to monitor how we're treating the patient. And the same thing, again, it's a VKH patient with a sunset glow fundus. Serial OCTs, we know how a macular hole is being developing, despite that the patient is on immunosuppressive therapy. So besides OCT, another interesting tool what we have is OCT-A, which is optical coherence tomography angiography. It's a non-invasive tool which maps the retinal and choroidal circulation. What we know is that it visualizes the occlusive and inflammatory changes in the choriocapillaries. And there are two interesting case reports where OCTA shows multiple flow void areas in patients with VKH and SO, and it corresponds to the hypocynosine spots on ICG. And these lesions, they resolve on treatment. And another interesting area where we need OCTA is it detects the neovascular membrane, as in all other uveitic conditions. So this is again from the paper published in OII, where these are multiple lesions, and we see these are the flow void areas, which are the hypo areas, and they correspond to what we see on ICG. And again, on the right side, the authors have shown there are multiple dark spots. These are the flow void areas. And at day 10, the flow void areas decrease, but they tend to increase as the disease is becoming recurrent, as we see here. By week 14, we see that they all resolve. So in conclusion, it's a challenge to diagnose sympathetic ophthalmia, especially when there is such a huge variety of phenotypes in the early stage. So it's important that we take a good history, clinical features, and we do a multimodal imaging. The ancillary investigations, they help us to determine the severity of the disease. How is the disease responding to treatment? And then we can detect the complications. But my favorite, I think it's OCT, where its diagnostic features, they may precede the clinical manifestations, and it's a valuable tool for screening, early diagnosis, and treatment. So I leave my talk here with this case, which I just saw in my clinic 2 days back, talking about the vitreal surgery. This is a patient who underwent vitrectomy in the right eye a month back. And this is the other eye. No, he underwent surgery in the left eye, which is doing fine. But now at 1 month, he complains that he's not happy with his right eye. He develops anterior uveitis with fibrinous reaction 5 days back. And what we see is choroidal detachment, retinal detachment, and a media haze with a tractional RD also in the inferior component. When I do the OCT, so look what we are seeing, these undulations, there is subretinal fluid. And what we also see these opacities here. And again, another frame also shows RPE undulations. And this is the ultrasound, which shows CD and retinal detachment and choroidal thickness. So is it SO? I would like the panelists to describe this now. Thank you so much.
Thank you very much. So I think we're going to do the discussion at the end. So maybe we can project that case at the end.
Sure.
And discuss it some more. So, but very nice talk, and it's always amazing what all you can get from OCT. So our next speaker is Cristina Muccioli, who is very familiar, I think, to most of us in the uveitis field. She's a professor of ophthalmology at the Federal University of Sao Paulo, and she's going to be talking to us about the differential diagnosis of potential sympathetic ophthalmia. Thank you, Chris.
Thanks, John, and thanks the IUSG to give me the opportunity to share our experience in Brazil. And sympathetic ophthalmia is a very rare bilateral and granulomatous uveitis resulting from autoantibodies target ocular tissues after penetrating injury or surgery. It can be a mild uveitis anterior or a severe panuveitis. The characteristic mutant fat KPs, vitreitis, papillitis, and serous retinal detachment are found in most of the cases. Dallen-Fuchs nodules is a classic finding occurring 25 to 35% of the cases, and OCT is very important now, showing the focal nodular hyperreflective lesions at the level of the RPE, as well as diffuse external limiting membrane and inner segment outer ellipsoid zone loss. We can always find subretinal fluid and choroidal thickening, which are present in cases with serous retinal detachment. Here you can see the very typical case of sympathetic ophthalmia. The key criteria for sympathetic ophthalmia is presence of bilateral uveitis with history or of unilateral ocular trauma surgery and anterior chamber and vitreous inflammation or panuveitis with choroidal involvement. We have the Sun group with the classification criteria published. Here are many different kind of trauma that can trigger the sympathetic ophthalmia disease. And as Manta just presented to us, we can see the suggestive lesions using the FA, like where we can find hyperfluorescence in the early phase and pooling at the intermediate or late phase. And the OCT that presents the very typical bullous serous retinal detachment. And talking about the differential diagnosis, we have to have this diagnosis for several infectious and non-infectious uveitis, but VKH syndrome is the most important differential diagnosis for sympathetic ophthalmia. Being the lack of history of antecedent trauma, the most important question to ask for the patient. And in VKH, we see more systemic findings than we see in sympathetic ophthalmia. But we have to consider another differential diagnosis, very important as well, like tuberculosis, syphilis, sarcoidosis, multifocal choroiditis, panuveitis, and chronic central serous chororetinopathy. And in older ages, we can also include intraocular lymphoma. But it's very important to rule out infectious causes and before we start the treatment for patients with suspicion of sympathetic ophthalmia. Here are the very suggestive cases, like we have for VKH, serous retinal detachment and bilateral, and it's very typical for VKH. But what if this patient has a previous history of trauma? Maybe it's sympathetic ophthalmia. Here is the key questions that we have to ask for patients, like to make diagnosis or to make the differential diagnosis for VKH and sympathetic ophthalmia. So remembering that sympathetic ophthalmia could happen in all ages, the trauma is always present. Skin changes, CNS findings, and hearing dysfunction are uncommon, and exudative retinal detachment very common, and CSF findings always usually normal. And here we present one case of a 30-year-old male white patient complaining about progressive blurred vision, photophobia, mild redness in the right eye for 3 days. And he referred a penetrating trauma ocular 4 years ago with extrusion of uveal tissue and one corneal suture. He also referred ocular inflammation in the fellow eye 1 year ago and was treated with oral and local corticosteroids. Here is the patient. 20/60 vision, low light perception, and here you can follow the injured eye and the fellow eye. So here is what we can see. We can find these Dalin Fuchs nodules, which are very common. And where do we grow from here? Like we have many no infections and many infections, differential diagnosis for all patients. That I used to say we have to have at least 5 differential diagnoses for each case, each patient. So, and we ruled out all the infections and no infectious causes, and we end up with this ultrasound presenting the thickening choroid and as well as retinal detachment in the fellow eye. And we end up with the diagnosis of sympathetic ophthalmia, and we found this epiretinal membrane for this patient. This is another very difficult and interesting patient of a 25-year-old male white patient complaining about floaters for 1 week. And he referred ocular trauma left eye 6 years before. The visual acuity was 20/30, and the other eye was no light perception. And he presented with mild anterior chamber reaction with granulomatous KPs, and the fellow eye was Uveitis. So here we can find a mild vitritis, a slight papilledema, and those multiple infiltrates at the retinal periphery. So in the fluorescent angiogram, we found early hyperfluorescent, either at the optic nerve and the chororetinal lesions, and no changes at the OCT. And here is the inflammatory eye, the trauma injured eye. And where do we go from here? We have many hypotheses. So it's just like because the patient has trauma, is it sympathetic ophthalmia? No, we have to rule out infectious disease. We have to do all the important exams, and we have to do the diagnosis. So for this patient, we found some changes, like the AC very elevated, and we end with the diagnosis of sarcoidosis. And the patient presented a very good follow-up, very good improvement after treated with corticosteroids. So this is another case of 33-year-old, actually a very interesting case, a male police officer with a history of 4-month severe progressive bilateral visual loss, episode of blurred vision, same symptoms after 6 months, and he said that the symptoms resolved spontaneously. He had a blunt trauma in the past, and he also presented recurring 6 months later with exudative retinal detachment and was diagnosed with VKH or sympathetic ophthalmia. Then he was treated with post-therapy with no improvement. The patient was treated either with high-dose prednisone for 4 months with no improvement, and another post-therapy with no improvement, and the patient was referred to our clinic. So he presented pigmented vitreous cells, no rhegmatogenic bullous retinal detachment with cerofibrinoid subretinal exudates on the posterior pole and inferiorly. The B scan presented bilateral RD with shifting of subretinal fluid with the changes of the head position, no signs of scleral or choroidal thickening. And the FA, we observe early hyperfluorescent foci with marked dye leakage from the choroid, followed by its extension and later staining of surrounding retina. And in the cyanine green angiography, presented the large hyperfluorescent patches in the choroid with multiple hypermeable areas. So here's the case. Count fingers, no vitreous cells, no signs of inflammation. Here you can see the appearance of the fundus, not very typical for sympathetic ophthalmia or Vogoyanagi harada. And here we can see this subretinal fluid and a kind of fibrosis. And here is the diagnosis. After a while, and after extensive medical and ophthalmological evaluation, we made the diagnosis of bilateral chronic central serous chororetinopathy exacerbated by corticosteroid therapy. So for this case, prednisone was tapered off over the following weeks, and the patient improved completely. And that's another very challenging case about a 27-year-old female white that present complaining of decreased vision with left eye for 1 month. She had a prosthesis in the right eye. She referred that she had this enucleated eye from trauma in childhood, and the VA of the eye, which patient was complaining about decreased vision, was 20/20, and no anterior chamber or vitreous reaction. The patient was being treated for multiple sclerosis, and we observed the multifocal choroiditis, and that's the question. Is that sympathetic ophthalmia just because of the ocular trauma? And here is a patient. We found those very atypical for choroidal findings, and that's the case. An immunodeficient patient with multiple sclerosis, she presented with multiple choroiditis. Is this sympathetic ophthalmia just because of the trauma? And we found that she was treated for a discharge on the eye with the prosthesis. So we decided to ask for evaluation of this material, and we collect materials, send to the lab, and then we had the candida diagnosis, and we treated the patient, and she presented with improvement. So after treated for fungi. So this is a diagnosis of multifocal choroiditis secondary to candida. Looks like it was, because she stopped to have the active lesions, as you can follow here. She had all the healed lesions and no more complaints. So Sympathetic ophthalmia is a rare, thanks God, disease, and I want you to take home this message. Not all ocular trauma means sympathetic ophthalmia. And we have to be very cautious, and we have to rule out infections prior beginning the treatment. Thank you.
So, well, thank you, Christina. So with this, we now move on to our next topic, which is management of sympathetic ophthalmia. And for this, we have Dr. Rupesh Agarwal. He's a senior consultant ophthalmologist at National Healthcare Group Eye Institute, TAN Talks and Hospital, Singapore. Over to you, Rupesh.
Thank you, Rima. Thank you, IUSG. Thank you, Professor Vishali. And thank you, Professor John Kempen, for giving me the opportunity to present on this important topic about management of sympathetic ophthalmia. I must say that the initial task of the management of sympathetic ophthalmia, the diagnosis and the differential diagnosis, has been made simpler by Christina and Mamta. And if I can get colleague clinicians like Mamta and Christina, I think my role will be more clerical about just managing the patients with steroids and the other kind of a treatment, because we are not looking really into the differential diagnosis. So, but importantly, I will take forward from what Christina just said in her last take-home message in the last slide, was about ruling out the infective causes. So I'm not going to go into the details of it, but once again, we have covered very well in Mamta's talk and Christina's talk about the diagnosis and the differential diagnosis. Once we have ruled out all the other possible differential diagnosis, particularly the infective causes, the management is relatively straightforward, it seems to be. But let's talk about the challenges and the way we should move forward, whether as a uveitis specialist or a non-uveitis specialist, depending on your comfort level about managing. So if you are a non-uveitis specialist, you are able to pick up. I think as Professor Pier Giorgio Neri very rightly said, you have to be a bit aggressive in your treatment. And now what do you mean by aggressive treatment? Is by starting the systemic corticosteroids soon enough, strong enough, and might be need for IV methylprednisolone, depending on case to case. Now, we don't have a consensus guidelines about whether each patient need to be put up on IV methylprednisolone to control inflammation, to prevent further damage to the sympathizing eye, because the inciting eye probably has been lost or might not have good vision post-trauma or sometimes post-complicated surgery, whether retina surgery or some other surgery, and then the only eye which is remaining. And therefore, you might have to be a bit aggressive, and it will depend on patient to patient how strong you want to go and hit the eyes with the steroids, particularly when we are talking about IV methylprednisolone. But a word of caution there is always make sure that you know your patient very well. Rule out any other things, systemic comorbidity happening in the patient, because all of us probably would have experience of burning our fingers when we are giving IV methylprednisolone, and the last thing you want is endangering the life of a patient. Subsequently, the role of immunosuppressive agent will come in, the biologic agents will come in, and a regular follow-up. So this is a kind of an overview chart, but let's get into the details about each one of that. And before we go into that, let's dig into the literature about a multinational case series published between Shankar Nethralaya Chennai with Mamta was one of the part as well. And then we have this in this particular case series where we looked into the medication, the immunosuppression, and the number of immunosuppression and the enucleation of the blind eye. So you can see between UK, South India, North India, and Singapore, the differences in the terms of the treatment given. So systemic corticosteroids was by and large given in almost all the patients there. Immunosuppression, once again, was also used. Biologics was not so commonly used in India, whereas it was used in as well in Singapore, but it was used with relative frequency in UK. And also periocular steroid was used in certain patients in South India and Singapore, so that as a supplemental therapy to ongoing steroids or in the people not able to tolerate systemic corticosteroid. Now, when we talk about the immunosuppression agent used, what are the different immunosuppressive agent used? Predominantly was the azathioprine. After that was cyclosporin, then the methotrexate, and then a good number of patients, there were mycophenolate mofetil, and particularly in UK. And one of the things which I will probably like to share here is the UK under NHS, mycophenolate mofetil is covered by NHS, and therefore it sometimes can be easier. And some other countries probably, if it is not covered in insurance, you have to think about a cheaper immunosuppressive, which can be azathioprine. But mycophenolate, the cost is getting better, and hopefully we can put up some of the patients on mycophenolate mofetil in case if they are not able to tolerate azathioprine. Tacrolimus was also used in certain some of the patients here. Now, number of immunosuppressants, again, there were one or more than one, or particularly 3 immunosuppressive agents were used in Chennai, Shankar Nethralaya, and the UK case series, and the enucleation of the blind eye was performed in a significant number of cases across all the line. Now, this is again about the first line, the second line, and the third line treatment between different types of immunosuppressive agent coming up from this particular paper. Now, this is again the duration of the immunosuppression agent used with the improvement and the deterioration, and was it directly correlated, or the enucleation duration, was it correlated? So both were not significantly correlated, the duration of immunosuppression or the type of immunosuppression used, or the enucleation, with the deterioration or no improvement in the visual acuity outcome in the inciting eye. This is another paper published in Indian Journal of Ophthalmology, and by Alok Agarwal from and Manisha Agarwal from Delhi, and Alok from Chitrakoot. And it is a review article in Indian Journal of Ophthalmology where they have kind of emphasized on the different types of immunosuppressive agent we can use. I've not gone into the details about each one of the immunosuppressive agent, but for those who are not really practicing uveitis, I think one of the other thing which you have to make sure that you monitor their systemic blood counts, particularly in patients with azathioprine. You are looking into the liver function test and the platelet count. In methotrexate, you are looking at the liver performance, the liver function test. Mycophenolate, once again, it is liver function test and the blood count. And once again, in cyclophosphamide, chlorambucil, and cyclosporine, you have to make sure that you are looking into the systemic factors, and then at the same time, there is no other thing. But if you ask, by and large, once again, there is no consensus about which one to use it. There are some people who prefer cyclosporine over azathioprine, but mostly, I think most of us, they do prefer still azathioprine. But once again, it is more from each one's experience rather than any evidence-based. I don't remember, except I think one of the paper from John or one of the group was highlighting on chlorambucil, and maybe John can highlight on what immunosuppressive agent he prefer in his if he has to encounter a patient of sympathetic ophthalmia. But nevertheless, azathioprine to me particularly, or mycophenolate, is one of the safest immunosuppressive agent, and because less side effects, a patient able to tolerate. And this is my preferred drug. Now, if I have to start azathioprine, I start with 50 milligram 3 times a day, or 50 milligram 2 times a day, depending on patient to patient. And I monitor them regularly for the liver function test and blood count. Now, over here in Singapore and some even in UK, we will be doing enzyme test called as TPMT test, just to make sure that they are the normal metabolizer for azathioprine, and the azathioprine does not increase it. So depending on the region where you practice, you might like to do that. Now, in case if this does not work, you might have to move to biologic agents, and some of the biologic agents being used is infliximab and adalimumab. And the other not say commonly being used is tocilizumab, which we are aware about it. Now, simple flow chart for once again some of the non-practicing uveitis specialist, or even sometimes it might be useful flow chart for some of the uveitis specialist also, is IV methylprednisolone has been given here, and or oral prednisolone. But I will probably put in oral prednisolone in a high dose versus the methylprednisolone in selective patient, and then accordingly you can differentiate. Followed by the oral prednisolone, which is tapering over 3 to 4 months or 2 to 3 months, and then at the same time, while this is kind of coming down, you start the patient on immunosuppressive agent, which can be azathioprine or mycophenolate mofetil. And once I'm putting them on, at least I tell the patient that it's going to be for at least 1 year and might need it for more than 1 year. Now, once again, I think there are some group of researchers who are working on the endpoints for when do we stop it. We really do not have any strong clinical indicator. Maybe some of the images which Mamta has shown about the imaging parameter can help us about when do we stop it, and probably we don't have to restart it again in next 6 months or so. But really, there are no strong clinical or imaging biomarker about stopping the treatment. So we take a call and then hope that the patient do not recur again. So improvement in the clinical condition, you continue or can stop it. And refractive cases, you might have to switch to another immunosuppressive agent, and some of the patients still not responding, you might have to move to biologic agents. Now, being IUAG talk, I think it will not go without touching upon some of the potential novel therapies which researchers on this forum, particularly Professor Dara Martin and some of the other people might like to be interested in looking into. Particularly, this was the work published in 2013-2014, though about some of the potential novel targets about CCL2, CXCL2, and gelatinase B, which is matrix metalloproteinase 9, may hold against this for the future treatment. And once again, treatment against the TNF-alpha, which we do know that may also be helpful in this patient. Now, this is about the medical therapy and some of the potential future personalized therapy or precision medicine, which can be helpful in some of the patients of sympathetic ophthalmia. Now, when it comes to the surgical treatment, so pars plana vitrectomy also has been described in the literature, and though not that commonly reported, some people have given adjuvant periocular or intravitreal steroid therapy as well. The most debatable question, which I think probably the questions must be coming on the forum also, about the role of enucleation. So the enucleation, when I'm talking about the enucleation, I'm not talking about the enucleation of the sympathizing eye. I'm talking about the enucleation of the inciting eye. And when I talk about the incision about that, so that comes as a prophylaxis, and does it prevent enucleation? And that is $1 billion question. Always we keep asking that. So decision to perform enucleation should be made on case-to-case basis, and particularly I'm being a trauma person as well. And one of the things which I am always giving a talk on the trauma forum also is about not to enucleate a severely traumatized eye just because of the likelihood of sympathetic ophthalmia development, because we are still able to manage. So after a proper counseling, if you can try and salvage anatomically the patient's eye, the badly ruptured traumatized eye, I think you can still go beyond the duty of your care or clinical care, and probably help us build a psychological comfort to the patient that you've given a best attempt in a no light perception eye or a badly traumatized eye. Some studies have reported the SON patient underwent the enucleation of the inciting eye with rates as much as 0% to 10% even after that, because already the process has started. Other studies have reported also between the 10 to 25%. And within 2 weeks of the eye being injured, the people have started the eye getting sensitized and the kick starting the process of sympathetic ophthalmia. So close monitoring of the contralateral eye is necessary after enucleation to detect any treatment of the sympathetic ophthalmia promptly. Now, this condition is not without complications, and the complications can arise either because of the disease itself or also because of the treatment which we are instituting, particularly the long-term corticosteroid. Now, we just talk about the treatment of ocular complications, can be associated with cataract, can be associated with glaucoma, or sometimes can be associated with the infections, or can be the retinal detachment, which can lead to that. So cataract and glaucoma is once again a very standard treatment, and there are papers being published on the management, but there is the principles of treatment of cataract in a uveitic eye and the principles of cataract in a patient with a sympathetic ophthalmia is more or less the same. Well control of the inflammation before you remove the cataract, and the intraocular lens has to be very careful because chances of failure of cataract surgery is quite high, and very intensive topical and systemic corticosteroid around the time of management. So prognosis wise, this is the last slide. So it depends on the severe factor, depending on the severity and duration of inflammation, the extent of ocular damage and response to the treatment, which can be very individual. With prompt diagnosis and aggressive and appropriate treatment, visual acuity can be preserved in most cases of SO. I think very beautifully demonstrated by previous speakers about the role of the treatment and how does it preserve the vision and the structure. However, severe and long-standing inflammation may lead to irreversible damage of the eye and may lead to permanent visual loss. Regular follow-up is the norm, and we need to make sure that these patients are under follow-up both for the disease itself and also for the complications which can potentially arise due to disease or due to treatment. With that, I would like to thank once again my colleagues from my USG for allowing me to present this talk, and thank you.
Thank you very much, Rupesh. So that was very good. I think it's very important for people to realize that this is a treatable condition and that we often do well with the treatment, and so not to be overly hasty to be enucleating eyes, especially eyes that have some potential. So our last talk now is back to Professor Dara Martin again, and he's going to talk about prevention and consent, risky patients and procedures. So I think trying to find out the ones that might be a real worry. Dara?
Thank you, John. So we're on to probably a very interesting and topical part of this whole issue, and that is is it possible to prevent sympathetic ophthalmia? We know that it's often caused by surgery. What issues are there surrounding consent? Are there particularly certain patients that are higher risk, and are there certain procedures that are higher risk? So we've seen from previous data that in developed countries, surgery, particularly repeat vitreoretinal surgery, is the highest risk by prospective data. But in underdeveloped countries, open globe injury still remains the highest risk, possibly due to delayed access to care, co-infection with dirty wounds. But this is retrospective. And if it were possible to do a prospective study on a nationwide basis, that would be very helpful. So who is at risk? What procedures have a high risk? Is there any way of preventing sympathetic? What's the role of prophylactic enucleation? We've heard from Rupesh there about enucleation being used both as a potential preventive prophylactic intervention, or indeed, could it have a role as a therapeutic intervention? And what are the medical legal aspects of sympathetic ophthalmia? So we've heard from multiple talks about the pathogenesis of sympathetic. We've seen that the risk is probably about 1 in 800 from one or more vitrectomies. And for one vitrectomy alone, it could be as low as 1 in 1,300. And Moorfield's data suggests it might be 1 in 12,000, but that's, in my view, a gross underestimation. And that's really a retrospective review and prone to case selection bias. We've discussed why vitrectomy might be immunogenic. And we've seen that from Tyaghi's work from India, that the risk of sympathetic ophthalmia, again, a retrospective series, after one vitrectomy might be 1 in 10,000, similar to the Moorfield's data. But we've seen that the highest risk was from multiple VR procedures from a 15-year cohort at Moorfields, particularly using retinectomy and silicone oil tamponade. So we know there are certain risky patients. Part of the BOSU study involved blood collection and HLA typing. And we've seen a significant association with DR4, particularly a subtype of DR4, 0404, and this haplotype of DR4 and DQ3 was particularly associated. So there was other data that was actually quite interesting in terms of the influence of this DR4, DQ3 haplotype on clinical phenotype. And you can see that those patients who had that had earlier onset, less than 3 months. They had also those that had that, they seem to be require more inciting events, and they also required more steroid therapy to actually control their uveitis. So with the British and Irish group, as in Japan, there is a HLA-DR4 gene variant association with sympathetic ophthalmia, but there's one specific genotype difference with 0404 in the UK and Ireland, and not 0405. Now that might have a theoretical difference in peptide binding affinity, and we've seen from published work from later on from that my cohort that S-antigen peptide immunoreactivity was greatest in both known immunogenic sequences and predicted high affinity and low affinity binders. So there may be an importance for their HLA type. And looking at this further, we saw that single nucleotide polymorphisms in cytokine genes can influence susceptibility and severity of autoimmune disease. And Denise Attan, using blood from our cohort, showed a significant association between IL-10 and disease recurrence and maintenance of steroid dose required. So we've seen that patients with DR4 and DQ3 have an earlier SO onset, but generally have a better visual outcome. So the immunogenetic profile determines the susceptibility to sympathetic ophthalmia, and the cytokine gene profile, particularly IL-10 and TNF, determines disease severity and, importantly, the response to immunotherapy. And indeed, it may influence the response to novel biologic agents, such as interferon, as shown from Jarka Pliskova's work. So what about the role of enucleation, possibly as a prophylactic agent or intervention? And I would contend that it's not indicated, because sympathetic ophthalmia is quite rare, particularly with trauma. It may be decreasing due to improvements in microsurgical techniques, wound toilet, and access to prompt repair. And an old study from Brackett et al. From more than 30 years ago from Southeast Asia showed that long-term follow-up of eyes that were severely damaged with open globe injury, 50 eyes, they weren't removed within 2 weeks, and not one sympathetic ophthalmia occurred in any case. And also long-term follow-up of patients with penetrating trauma and subsequent enucleation of these eyes showed no sympathetic ophthalmia on histology. So we may be enucleating eyes unnecessarily, and it certainly doesn't work to prevent it. We've seen that an immunogenetic predisposition in sympathetic ophthalmia. So say if you have a patient with penetrating trauma and you're not sure whether they should have an enucleation, you send them off for HLA typing and it comes back as this dreaded phenotype of DR4, DQ3. It does increase the risk, but the risk is still low. So it increases the risk about 6-fold in white patients, but in Japanese patients about 14-fold compared to normals. The prevalence of these gene variants is reasonably high, like about 20%, but the instance of sympathetic ophthalmia is still very low. So even if you have these gene variants, your risk of getting it is not, in absolute terms, not very high. So that in itself would not justify prophylactic enucleation. And where does this 2-week rule come from? Well, it comes from very old data from the 19th century and from the early 20th century, before we had adequate immunosuppression and before the overall prognosis for sympathetic ophthalmia was being shown, with early intervention, was being shown to be quite good. So it's probably too late if you're enucleating somebody within that 14-day period. For example, the clinical onset has been shown to occur as early as 5 days after injury, with the earliest histopathological confirmation being shown 10 days after injury. So it can occur well within that 14-day so-called safe period. And in experimental animal models, T-cell activation and tracking to regional lymph nodes has been shown as early as 40 minutes. So unless you're getting in there extremely early, you're not going to prevent release of your retinal antigens and immune activation. And we've also shown that sympathetic ophthalmia can occur despite enucleation or evisceration before disease onset. And this is well described, and indeed it happened in one patient in our cohort. And I'm going to raise the potentially novel idea that leaving an injured eye may have actually some degree of benefit. There may be the release of regulatory or suppressive factors preventing sympathetic ophthalmia. There may be the posterior segment counterpart of ACAID. So the RPE may downregulate uveal inflammation by secreting TGF-beta and other factors. And there may be a novel RPE protective protein that inhibits phagocyte generation of superoxide mutants. And posterior segment autoimmune deviation, where you have release of endogenous regulatory factors secreted by the RPE, may downregulate the immune response. And this might account for the relative sparing of the retina and choriocapillaris at sites of intact RPE and sympathetic. The evidence supporting early enucleation after sympathetic ophthalmia onset was quite flawed. It's based on only 2 retrospective studies from the pre-immunosuppressive era. And Lubin et al. From quite an old paper looked at these old studies and showed that there were significant methodological errors. There were varying numbers of patients and inclusion criteria throughout the paper, quite subjective with vague grading criteria. And in fact, Lubin in this paper misquotes a more careful and extensive study by Winter et al. Showing no effect on enucleation timing on final vision. And that paper from 1980, the same author produced a later correction stating that an eye with useful vision should never be enucleated in sympathetic. And a smaller study from 1983 showed that patients who underwent early enucleation had a better outcome, but out of those, the vast majority received steroids, so a significant confounding factor. So recent studies showed no effective enucleation on visual prognosis, and that prospective and retrospective studies usually show a very good visual outcome with rapid and adequate immunotherapy rather than enucleation. From Chan's paper from 95, from the prospective study that we reported in 2000, and indeed other meta-analyses from more recently. And our paper showed that 75% of patients can achieve 6/12 or better vision in the sympathizing eye at 1 year with rapid adequate immunotherapy. So we may be seeing very soon selective antigen-based tolerance therapy. We've seen that the long-term follow-up in some patients in the sympathizing eye may have worse prognosis in very rare situations than the exciting eye. So why would you remove an exciting eye that might have visual potential? And remember that sympathetic ophthalmia is a bilateral disease. An enucleation of the exciting eye does not remove the source of inciting antigen. You've already got the blood breakdown barrier and release of uveitis antigens in the sympathizing eye. So just removing the inciting eye may not have an ameliorating effect, and there's still a significant source of antigen in the sympathizing eye left behind. So what about medical legal risk? Well, the Australians were well ahead of us, showing in Rogers versus Whitaker that the informed consent principle changed irrevocably. Before that, and really up to 2015 in the UK, this relied on the Bolam principle, where the standard of reasonable care was regarded as sufficient if an ordinary skilled practitioner exercised the skill of an ordinary competent practitioner exercising that particular art. But we've moved on from this with Rogers versus Whitaker, where a patient had Rogers sued the surgeon where the surgeon operated on a blind eye for a cosmetic procedure to correct pupil abnormalities, and ended up with sympathetic ophthalmia in a previously healthy eye, in the contralateral eye. And that risk was not disclosed because it was deemed to be so small as not to be a meaningful risk. But the High Court in Australia found against the surgeon because it was deemed to be a material risk. And so our duty of care is now to ascertain what is a material risk specific to a particular patient. And this has been confirmed in the UK in an obstetric case from 2015, in a case of shoulder dystocia. And the duty is to determine in consent what importance a patient would attribute to that actual adverse event. So moving away from the doctor determining what they would think would be an adverse event to our duty of care being to ascertain what a patient would think would be an adverse event. So to conclude, sympathetic ophthalmia remains rare. The risk is low and probably decreasing from surgery, from trauma, but increasing because we're doing an increasing amount of retinal surgery. And the risk after surgery is small, but the potential consequences are great. And this changes our whole idea of informed consent. So I'm going to conclude my talk with that and pass it back to the chair of the webinar. Thank you.
Thank you. Thank you very much, Dara. Thank you all speakers. Thank you, Rima and John, and time for the controversies. So my first question is, you all beautifully showed that based on the clinical imaging and presentation, you know this is a case of sympathetic ophthalmia. And then Christina also showed that there are infections and other things which she would like to rule out before starting treatment. So my question begins with Dara. You look in the clinic, you know it is sympathetic ophthalmia. Is there any minimum investigation you would do before starting IV methylpred, or you would start with the therapy straight away?
I suppose I would come back to first principles here, Vishali, and you mentioned this earlier, and that is always to be sure that there's no underlying infection. And with anyone undergoing immunosuppression, I would always insist on quantiferon testing.
Dara, if I might interrupt, would you wait for the results of the quantiferon to come before you start steroids?
Not steroids, no. But immunosuppression, yes.
No. I'm just talking about steroids. Like you have seen the patient in the clinic and you know it is sympathetic ophthalmia. Would you start steroids there and then, or would you wait for 24 hours or 48 hours for some investigation results?
Well, you said that I know it's sympathetic ophthalmia. So if I know it's sympathetic ophthalmia, I would go in and treat, because generally speaking, sympathetic ophthalmia is quite aggressive. And in a case of very indolent, low-grade inflammation, you do have 24 or 48 hours, or if it's presented to you very delayed, there's no reason why you wouldn't wait for a few days to be more sure in yourself that you're completely 100% certain that you've ruled out any other causes of infection. But if you have a very aggressive case, I would intervene with steroids immediately.
So Christina, can I have your take on this? What Dara said, you agree, or would it be different for you?
I agree. I think if you have a very aggressive patient, like you know it's sympathetic ophthalmia, and you have no signs of infection or whatever, I think I started right away with corticosteroids, and then I asked for exams, and maybe, you know, I'm not scared about using steroids for this situation, because you have to consider like risk benefit. So, and if you lose your timing, it may be very harmful to the eye. I think it's my opinion, my way of treating my patient. So
I totally agree with you. And with this, I come to Rupesh. Rupesh, now suppose there is a situation like we agree, we saw, it has all the classical features, typical sympathetic ophthalmia. We decide that we want to give steroids. Now, what if there is a contraindication and you cannot use systemic corticosteroids? What will you do to this patient?
Thank you for that question. I've got probably 3 different time points when different patients have contraindication to steroid. So the option is, again, depending on the severity of the case. One of the case was having very mild inflammation. We managed with the topical steroid, but that patient, we ended up still giving periocular steroid. So that was all right in that patient because the patient was okay. And we never given immunosuppressives in that. So that is one option, is if the patient needs steroid, depending on the condition of that, periocular steroid can be offered or intravitreal steroid can be given. Second option is, of course, starting with the immunosuppressive agents. And one of those things can be, we can start depending on, again, the condition, we can start with the immunosuppressive agents, but immunosuppressive agent does not kick in very early. And even if you start, there is still degree of inflammation. Those cases definitely will require aggressive topical steroid, and depending once again on the case, might require either a regional steroid in the form of either intravitreal or periocular steroid. So that will again depend on that. Again, not that many. We can some of these patients we have given a very low dose steroids, but low dose systemic steroids. I'm trying to say that. But some of the patients, they just don't tolerate. Rather, one such patient I have got in my clinic, admitted not for sympathetic ophthalmia, but for another condition where he just can't tolerate even 5 milligram of oral prednisolone. So those are very difficult patients to manage. So I think, yeah, so we have to just manage on some of the immunosuppressive agents or biologics. Yeah.
Now, Rima and Mamta, I have slightly more difficult scenario for you. There is a patient who has history of central serous chorioretinopathy. And now you look at it, you know there is sympathetic ophthalmia, but the patient has had CSA in past. Mamta showed beautiful OCTs and ICGs. You know it is sympathetic. You know you cannot give systemic, and you also know you cannot give regional, like Rupesh is telling here. So Rima, first to you, what will you do in such a scenario? I know it's very rare, but still, you know.
Yeah, I agree. It's very rare, but I have managed some very few of these patients because sympathetic ophthalmia is such an aggressive disease. I don't think I would ignore giving steroids to these patients, but at the same time, I'll keep them under a very close watch, counsel the patient that his or her CSR is likely to worsen. But since we are starting the immunosuppression right from the time of admission, I'll just keep them on close watch, give steroids, at least to, wait for the exudative RD to settle. And fortunately, I've not seen the CSR worsening in the patients that I have treated. And I quickly taper once the, exudative RD settles down. I quickly taper the steroids and allow the immunosuppressives to take over. So we've demonstrated also that the CSC disappears on fluorescein angiography pre and post treatment. So, but a very close watch, and IVMP does well in these patients. The other thing is about the locals. Posterior subtenon, I think I would not give in these patients who have CSC. Ozurdex also, because they have massive RDs, retinal detachment, sometimes even choroidals. So I would not go in with the intravitreal injection. So for me, the safest is IV methylpred, close watch, and in case the CSC worsens, I would stop that and just maintain on immunosuppression.
Mamta, what would be your take in such a scenario about starting biologics? Like Shahana is asking, even intravenous cyclophosphamide. And I was in fact surprised at what Rupesh showed the Indian journal paper, that you first give cyclophosphamide, and if that fails, move on to biologics. I thought it was like, I would like your, and of course then John Kempen's opinion on how would you go about, if not steroids, what would be your choice?
I think I would slightly differ with Rima's opinion, what I have experienced. Like if I'm not comfortable with steroids because of this CSR history, and again, it depends upon the severity, how aggressive we need to be. So IV pulse cyclophosphamide still is on my cards because not every patient is fit for biologics. And so between the two, I think I would still think about IV pulse cyclophosphamide, and it's pretty prompt in action. And simultaneously, we would start on the systemic other immunosuppressive if steroid is really contraindicated. And biologics, yes, it is definitely a next option. Like if we have this rituximab and adalimumab, which are easily given now by the rheumatologist. So I think I would think about those options also. But having said that, steroids, I would be cautious even with IVMP patient is this thing.
Yeah, and there is a comment, John, by Ilkanur, like why not biologics as first-line therapy in these? I would like your opinion on that.
Well, I think that steroids are the fastest acting medication. So if you have really severe inflammation, you'd like to treat with steroids. And then a CSCR patient might get worse with that, but it might be better than like leaving an exudative detachment or really severe inflammation. So that's kind of a judgment call. I don't know if I think there's an impression that like TNF inhibitors work faster than conventional immunosuppressants. I hope they do, but I don't think they work as fast as steroids. So that's the difficulty with that. So, but a TNF inhibitor or some other biologic, might be a good option for someone who has a high likelihood of having difficulty with steroids. Occasionally, it might be like, say you have a brittle diabetic or someone who's likely to have a lot of treatable difficulty from steroids. You might even put them in the hospital and, monitor their glucose and just make sure that they don't get into ketoacidosis or something. And then during that time, maybe you see that they're having a good response, so that could be an option. Obviously it's just, there's some problem with all the options in the scenario that you're saying. But I think if you have aggressive inflammation, you want to treat with steroids. If it's less aggressive, maybe you could try other things. But the conventional immunosuppressants, I think, really take quite long. And so I don't know that would be a great substitute for steroids, although it's certainly a great adjunct to steroids in the long run.
Dara, there is a question from Dr. Wen that can Dehlen-Fuch nodules be used as a biomarker for titrating your treatment response during management?
Yes, I saw that. Yes, of course, because they're a form of choroiditis. So you would assess clinically any response to treatment, any of the signs of ocular inflammation. Dehlen-Fuchs have been very highly associated with sympathetic ophthalmia, but you don't have to have a Dehlen-Fuchs nodule to diagnose sympathetic. And any degree of posterior segment, manifestation of posterior segment inflammation, any of those markers can be used to assess response to activity. So yes is the answer, but I wouldn't get fixated on just the idea of using Dehlen-Fuchs. All of the manifestations of posterior segment inflammation would be used as clinical markers of response to treatment.
I think Dara raised a point and he answered it somewhere that following trauma, corticosteroids will not really prevent the breakdown of the barrier. So giving corticosteroids after trauma is not going to reduce the incidence of sympathetic ophthalmia, if I understood correctly. And there were two questions related to it. And I would like Christina and Rima to answer this, that when you give corticosteroids after open globe injury, do you think it's going to reduce the incidence of sympathetic ophthalmia or not? Should our friends out here be giving it or not?
I really don't think so. I don't think giving corticosteroids after trauma will prevent anything. So that's my, it's a rare disease. I don't think any of us have a huge series of cases to evaluate this or whatever, but I really don't remember any case of patient that will have prevention of sympathetic ophthalmia by using steroids. So that's my impression, but I don't have any publication or any study to prevent this. It's just, personal impression. It makes no sense for me.
So there is no consensus. So when the patient presents with trauma, we give steroids not for preventing SO in the fellow eye. We give it depending upon how badly the injured eye needs. So it is the need of the injured eye for which we give steroids and not for the fellow eye.
Let me
Mamta
just make a comment. Could I just make a comment? Just from an epidemiological perspective, if you have an incidence of sympathetic of 0.01% and you have, if you assume that treatment with steroids at the time of injury would prevent it 100% of the time, it's still sort of, what is it, like 1 in 10,000 or less you'd have to treat, the number needed to treat is like 10,000 or more if I have my math right. So it seems like it's kind of difficult to recommend that based on that consideration.
And also when we know that Dr. Dara's talk, I understand there are genetic predisposition. So it's not just the trauma which makes the whole thing, because there are other factors also which may predispose to the development of sympathetic ophthalmia in one particular patient. So maybe that also is a factor, saying that giving steroids, are we preventing it? We are not preventing because we are still seeing it.
Now, Mamta, you showed those beautiful images. When you are giving high dose steroids, like 1 to 1.5 milligram per kg to begin with, how would you know when to start tapering them? Would it be based on the clinical judgment? Are there any imaging biomarkers you are looking at?
Not really. The answer, I would say, the severity of the disease, which again, we actually judge all the ancillary investigations and mainly OCT. So how bad is the subretinal fluid? How bad is the bacillary? All the features which I actually showed. So I think the severity of the disease is the treatment tapering depends on that, on one aspect. Having said that, but we start high dose steroids and taper in a very regular fashion, as we do in our any very severe uveitis, and we start immunosuppressive immediately. I start it at least with at the same time. We don't wait that the steroids are tapered and then you add the immunosuppressives. So,
and Rupesh, you mentioned about MMF, methotrexate, and Azuran and multiple drugs. So when would you start it, and what you said John will answer this question. So I go back to, after you to John, what will be the easiest immunosuppressive drug to start, considering most of the participants in this webinar are from sub-Saharan and other countries where, they always may not have an internist monitoring it, and they may not have the fanciest of the drugs available to them.
Yeah,
so first Rupesh and then John. Yeah.
I'll put my money on azathioprine because of my understanding of the azathioprine, the ease of giving it, lesser side effect, low cost, and I do know how it will behave. I will start it, as Mamta very rightly said, soon. So after the IV methylprednisolone dose is over, when the oral steroids have kicked in, within a week of that, when the patient is on, let's say, 60 milligram per day, or that time itself will start. And slowly, the steroid will come off in 2 to 3 months. But azathioprine will start with 50 milligram 3 times a day, depending on a normal body weight person. And we'll continue with that dose for 3 months at least. And after that, if things are good, then I will, after 3 to 4 months, we'll cut down to 2 times a day, 50 milligram 2 times a day, at least keep it for 6 months or so. And if the disease is resolved or treated by the time, then I would try to keep it as a maintenance dose after 9 months on once a day for at least 6 months to or so, and at the same time monitoring the liver function. So that is my preferred thing there. And after that, if I don't know, then I refer to John. John says.
So John, tell me one thing. Is there any logic of tapering immunosuppressive drugs?
Were you asking me?
Yes. Can you
Yeah.
reduce the dose of azathioprine over a period of time where you want to use them on long-term basis? Because many a times we all do it. We are scared. We keep on reducing. We do have our patients on like 5 milligram prednisolone and 2.5. So steroids, I understand. But is there any science of reducing the dose of immunosuppression?
So I think that Nisha and colleagues are doing a study about removing immunosuppression in JIA cases, and maybe that will give us a little bit of guidance about it. But over my career, I've sort of noticed that the amount of time that people want to suppress patients with immunosuppressive drugs, it keeps growing and growing. We have pretty strong evidence that the drugs are safe as long as they're being tolerated. There aren't lab abnormalities or, feeling severely ill or different things. And so there's kind of not super strong motivation to taper off. I think, I've tried with my colleagues to do a series of papers about the incidence of remission of uveitis, and it's not very high. And then I guess I have the impression with sympathetic, it may not be high at all. So I don't know, for those who have more experience than me, I think many of us haven't seen very many cases permanent or personally, but does it really remit? I think unless you're, having some strong indication to stop the medication, or else if they've been controlled a very long time, maybe it's worth trying. But I don't feel like we're pressed very hard to stop it, and then if you had lesions that are likely to cause permanent vision loss if they relapsed, and I think that may not happen too often with sympathetic, but then you would be wanting to treat longer. But at least if they're tolerating, we don't have big worries about safety in the long run, as long as they don't develop active cancer or something that, like, maybe we should stop immunosuppression if they're apparently successfully treated for cancer and we're trying to avoid a relapse. But in terms of incidence of cancer, I don't think, or death, there's not much reason. Yeah.
Yes, Martha.
So I guess this is a very important topic that we brought here, that should we taper immunosuppressive agents? So I think we recently had a discussion with our rheumatologists also. So they also believe that the immunosuppressive should not be tapered. So there are two terms. What we know is therapeutic dose and the maintenance dose. So when we treat a patient with 3 times a day azathioprine or mycophenolate, 2 tablets twice a day, that is 1 gram twice, that's what we are talking about, the therapeutic dose. And we continue in all our uveitis patients, the therapeutic dose for a year or more, if we do not see any recurrence in that 1 year. So let's say they say that if at 1 year we have 3 times a day azathioprine and we do not see any recurrence, that's the time you can think of that, let's make it 2 times a day and then continue that for next few years, because you just have to monitor. But there is no concept of tapering every 3 months or every 2 months, because it starts to act only after a month or 2. And that's when we start to reduce the steroids. So at least for a year, the therapeutic dose should not be reduced in all these diseases which we know that they're chronic and we don't really see remission so easily for a few years. So that's my pointer. And I do not do that either. Like, I think I saw with Nisha's clinic also that the therapeutic dose runs for years till we see not any recurrence. Any one episode comes back and again we are back to square one with high dose of steroids. So to avoid that, we continue.
So any experience, Dr. Ashraf is asking, Retisert are long-acting steroid implants. Dara, do you have any experience?
Yes, I do. I do, but I wanted to actually comment on that. I think that I think it's, unless there's a severe problem with systemic treatment, that one should avoid regional injections or any regional steroid therapy or any regional immunosuppressive therapy. In the case of sympathetic ophthalmia, you're already dealing with an eye that has had a breach in the blood retinal barrier. And I think that the idea of giving intravitreal injections particularly, or I'd have less of a problem with periocular injections, but giving intravitreal injections, which is essentially another surgical procedure, is, to me, anathema. It doesn't make sense to add petrol to the fire of sympathetic ophthalmia. Okay, you have patients who are immunosuppressed and you might be topping it up, but I think you should always think of systemic treatment rather than local therapy in a case of sympathetic ophthalmia. And also on the point about withdrawing immunosuppression and when to taper, remember, sympathetic ophthalmia is a unique situation for us, where we can actually see the cause of the autoimmune disease, which is the damaged eye. And usually you're dealing with the situation where you have an only functioning eye, the sympathizing eye. And you cannot afford to have a recurrence of ocular inflammation in the sympathizing eye. It sets the patient back. You have to reinstitute higher doses of systemic treatment. And sympathetic ophthalmia just never goes away. It's a relentless, inexorable condition where you've got permanent breakdown and loss of the state of immune privilege of the eye. And you need long-term permanent immunosuppression, in my view, albeit at a very low dose. You can bring the dose down over years, but I'm very uncomfortable about taking patients off immunosuppression ever.
I think that's a very important thing. We are very uncomfortable in taking them off. And that is my last question to all of you. How long have you treated them with immunosuppression? Like your patients, for how many years they have been? And this is my last question, beginning with Rima. What is the longest immunosuppressive drugs you have given to these patients?
I think up to 3 to 4 years is the longest. And
4
on an
years?
average, 1.5 year, maybe 12 months, 18 months, or max 24 months.
Christina? You're muted, Christina.
Yeah, no, I'm okay. I was just thinking, well, it's a very difficult question because I think we have all the situations. There are some patients that we can remove the immunosuppression. Like I think I will say I use at least 1 year, and then depending on the follow-up on the response, I will keep the immunosuppression until it is needed. So I don't have a time like 1, 2, 3, 4 years. It depends on, but I like personally, I like to remove patients from immunosuppression as soon as possible, which means could be 1, 2, 3, whatever. I don't know. I don't have this precisely answer. That's the way that I do, depending on each patient, each case, each aggressiveness, or each complications from patients. So it is very a complex question for a complex answer.
Rupesh says it's 3 years for him. And Mamta, you also have to answer. What is the maintenance dose for azathioprine? Manjari Tandon is asking.
So maintenance, again, I don't say that there's some people, they can be maintained on 2 times a day for years together, and then we bring it down to 1 time a day.
You're talking about 50 milligram a day, 2 times,
Yes,
maybe
50
25.
milligrams twice and 50. And coming to your question, I would say that I have a patient, a pediatric patient, definitely needs much longer immunosuppression than an adult. That's my experience, like a pediatric VKH, which I'm treating for the last 8 years, and he's still on immunosuppression as a thioprin or methotrexate. For that matter, even pediatric intermediate uveitis. But they can definitely go longer than 5 to 8 years. At least I could say that. I don't stop at least a year or 2. That's too short for me.
I think the eventual message is that you have to be very careful in stopping it, because if the disease comes back, you have to go all the way up again. So it has to be stopped, but be careful before stopping, making sure that everything is quiet and under control. If
And even
any of,
serpiginous uveitis, your disease.
any of
I have patients on immunosuppression for 20 years with sympathetic ophthalmia and longer. For as long as they're going to be my patients, they will be on immunosuppression.
Sure.
I think it's important to remember. I think it's important to remember, it might take several months to have the benefit from immunosuppression. So you don't really want to be you don't want to have a short course. I mean, I think it should be like at least 2 years for most patients,
And we know quite a lot about these medicines now, that the side effects, we should not be so worried. We have to be vigilant. But I think these drugs, what Rupesh said, azathioprine and mycophenolate and methotrexate, they're quite safe to use for long term. So I think we are quite good in these things.
I think it's also very important point which John has brought up, that very fact you have started immunosuppression doesn't mean you can taper off your corticosteroids very quickly, because they take time to act. And don't be in a panic to change them too often, because it takes time for them to act. So the proper dosage and proper monitoring, they are very safe. Thank you, guys. Thank you, all of you, for being with us. And we meet again on 6th of May with a very, very important topic of vitreoretinal lymphomas. Thank you, Rima and John, for being there. And thank you all the speakers for taking time out of your Saturday evening for IUSG. And thank you, participants, for being with us and asking all the questions and being interactive. Please fill in
And thank
your
you, Vishali,
evaluation
too.
for CM.
Thank you,
Yeah.
Vishali. Thank you, everybody.
Yes.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye.
Bye-bye.